Okay. All right. So I hope you guys can hear me okay. And thank you so much for having me. This is my passion, just like you said. My goal is to help young women to learn about their bodies at the beginning so they can know what's normal and what's not normal so that we can have these diagnoses that you mentioned earlier so that we can manage them and treat them appropriately so they won't be so bad for your entire life. They won't cause issues your entire life. We can hopefully control them. So just like Ms. Odelia said, I am a pediatric and adolescent gynecologist. And what that means is that I do have specialty training in the gynecological care of young girls, teens, as well as young women into young adulthood. And with that being said, we're going to start with our periods. I'm going to talk about how they occur. So we're going to take a little history lesson, a little biology history lesson. We're going to discuss how they occur, why they occur, and then we're going to talk about the normal periods versus the abnormal periods. So let's go ahead and get started. All right, so let's start with puberty. So puberty is where it all begins. So during puberty, our bodies change. Our bodies change in their shape, and we get taller as well. So our hips start to expand. We start to require breasts and need bras. We also start to develop hair in the axillary areas as well as our genital areas. In these areas, you also will notice that you start sweating and developing body odor. So you may need deodorant. And then you also notice on your skin, pimple formation, or what we call zits. This can be located on your face, your chest, and your back. And the last thing that usually actually happens is your period. That's one of the last things that happen. You do continue to grow a little bit after your period starts, but the very last thing is your period. So when do your periods start? Your period can start anywhere between the ages of 9 and 16, but the average age over the spectrum of young women is age 12. This age is actually genetically determined. So what that means is that depending on your family's history is when your period will usually start. So if your mother, your sister, your aunt, if their period started around the same ages of 11 and 12, that's around the time your period will start too. But that being said, there are some conditions that can delay your period from starting. Let's say if you are a very active young lady, you are part of a team, you're a swimmer or part of a sports team, and you're practicing every day, exercising for many hours in the day, you can actually delay your period because of that activity. The other reasons you can delay your period is because of chronic conditions, chronic medical conditions. Let's say you were born with a chronic medical condition such as diabetes or a thyroid disease. If these conditions are not well controlled, they can affect when your period actually starts. And sometimes even the medication that you take or the treatment that you have because of the condition can cause your period to be delayed. If you've had cancer as a young lady and you've had radiation or chemotherapy, that can delay the start of your period. And the other thing that can delay the start of your period is also your diet. Let's say your diet is restricted for whatever reason. So you're restricting what you're eating, which can actually put you at a lower body weight. So you may be smaller than the average for your age. That can delay your period. But in general, when your period starts is genetically determined, and then you may have a couple of conditions that can delay them. So let's figure out how your body produces a period. Now, this is the biology lesson I was telling you about. So it covers many different organs. So let's start in your brain. You see a picture up here of your brain. And at the base of your brain, this hot pink area, this is called the hypothalamus. And if you can see here, this little dangling area here is highlighted here or enlarged here. This is the pituitary. Pituitary is actually divided into two different sections, the anterior pituitary and the posterior pituitary. So the hypothalamus is important. It produces a hormone called gonadotropin releasing hormone or GnRH. This hormone then tells the anterior pituitary to produce two other hormones, the LH and the FSH. LH stands for luteinizing hormone. FSH stands for follicle stimulating hormone. These two hormones then talk to your ovaries. Now we've come from the brain down to your tummy where your ovaries are located. Your ovaries then produce hormones called estrogen and progesterone, which are very important in the regulation of your period. And we're going to talk about that in detail coming up very soon. Also, the estrogen can be converted to testosterone. Yes, we as young women and women have a smaller amount of testosterone than men, but we do have testosterone, which is very important in our bodies because that's the hormone that actually produces the hair underneath your arm and in your genital area. We'll talk about those in detail coming up. But briefly, I want to talk about what the purpose of having your period is, because there is a purpose. So their puberty and having your period, it changes you from being a young lady to an adult woman. And when you become an adult woman, you may want to start having your family. So the purpose of having your period is actually to have your family and to procreate. So what exactly is happening within your body when you're having your period? We've already talked about the hormones slightly, but this is the slide that is very important to what we talk about next, the normal period and your abnormal period. So I want you to really focus on this. This is a chart that shows you what's going on inside your ovary, the hormones inside your anterior pituitary, the FSH and LH, inside your ovary, the estrogen and progesterone, and also what's happening inside your womb or your uterus. And if you look at here, this is divided into color schemes as well. So everything in pink is happening at the same time. Everything in green is happening at the same time. And then you have the orange section, which we'll talk about soon, as well as the blue section. And these are the different phases of your menstrual cycle. Yes, your menstrual cycle is actually encompasses this entire thing. Now your menstruation or your period, your menstrual flow is here in pink. So this is where we'll start. The menstrual cycle actually starts with the first day of your period. During that time in your ovary, you are actually developing your next egg or the next follicle for the next month. So during your period, you're starting to develop this. And at this time, your FSH is actually higher. So the follicle stimulating hormone, look at the word follicle stimulating, the follicle stimulating hormone actually develops the next follicle. At this time, your estrogen is higher than your progesterone. And then once your period ends, you enter what's called the follicular phase. The follicular phase shows that the FSH is decreasing. So you have the follicle with the egg inside that has been recruited already. During this phase, that follicle starts to mature. Your LH is starting to become higher in this area because it's very important during this time. Your estrogen is still higher than progesterone. And actually there's going to be a little peak in a few minutes. And during this time, when your estrogen is higher, the lining of your womb, where you're having your period, is starting to become thicker and thicker, preparing for your next period. At the end of the follicular phase, you'll see here that the LH, luteinizing hormone, peaks. You have a spike right here. When that occurs, you then release that egg from that follicle. It's called ovulation. So that's the orange line, ovulation. During this time, your estrogen level goes up as well, and your LH and your FSH peak slightly, LH more than FSH. Now, I want you to then now come look over here at this picture, and you can see the same thing happening inside your ovary there. You see that the follicle here releases the egg, and now you have your egg being ovulation and released into the fallopian tube. This is your fallopian tube, which is connected to your inside of your womb right here. Let's go back to the chart. The next phase is your luteal phase. During your luteal phase, the progesterone level increases. This is due to the cells that are now making up what used to be the follicle. It is now called the corpus luteum. The corpus luteum is actually very important during this time because it's producing progesterone that's stabilizing the uterine lining during this time. Again, listen to what I said. Progesterone stabilizes the uterine lining, and this is going to be important when we start discussing abnormal periods. You see that the estrogen level is still fluctuating some, so the lining is still becoming thicker and thicker than this during this time during the luteal phase. Here you can kind of see a representation of that, and this is before your period starts. So if the egg stays in the fallopian tube and is not fertilized, it will then go into your uterine cavity and disintegrate. It goes away. When that happens, progesterone levels, well, the corpus luteum actually starts to go away also. It starts to disintegrate and regress. Progesterone levels start to decrease as well as the estrogen levels. And when that occurs, when the decrease in the progesterone and estrogen go down, that's when you start to have your period. So this is your normal menstrual cycle, which includes your period, the follicular phase, ovulation, and the luteal phase. All very important in having a normal period. So your normal menstrual cycle, again, that's the entire time. So I have a picture over here again so you can look at it while I'm talking, is from the first day of one period until the first day of the next period. That's your menstrual cycle. And this cycle usually lasts anywhere between 21 and 35 days. This is considered normal. Now, it's not normal for each individual for that day, the number of days to change greatly. It should stay around the same for a single individual. So if your periods are 21 days apart, they'll be 21 days to 21, 22, 23 days apart each month. If they're 28 days apart, same thing, and 35 days. It should not fluctuate one month being 21 days and next month being 35 days in the same individual. Again, I said that the menstrual cycle is divided into phases, and the cycle can change and is variable in those first few years after you start your period. Remember, you start your period around the age of 12, anywhere between 9 and 16. In those first 5 to 7 years, it can vary. So initially it may be irregular, then it may be 21 days apart, and then eventually it can self-regulate into 28 days apart, or what's going to be normal for you. This also starts to vary at the end of your menstrual life. So around the time of menopause, it can start to change as well. Your menstrual period, now this is your menstrual flow, normally lasts between 4 to 8 days. That's normal. And the normal amount of blood loss is between changing your pad or tampon, it's just one, your pad and tampon every 3 hours or more. That's considered normal. But now let's talk about when things are not normal, okay? The first thing we're going to talk about is abnormal uterine bleeding, changes in your menstrual pattern. And we're going to talk about each of these individually coming up soon. Let's first start with amenorrhea. The word itself tells you what it means. A means no or nothing, and menorrhea means your period. So this means your period has stopped or you don't have a period at all. This can be transient, meaning it can happen every blue moon, not frequently at all, and it may be related to just stress. That can happen, and as long as your period comes back the next month, it's fine. It can be intermittent though, happening more frequently than being transient, or it can be permanent. If it's permanent, that means that you had your period, but it has permanently stopped. This can be caused anywhere in the system that we talked about, whether it could be due to abnormal hormones, or it can be due to a structural cause inside your womb, at the level of your cervix, even at the level of your vagina, which is this area down here. Amenorrhea can be separated into two different types, primary and secondary. Primary means you never had your period. So now you've reached the age of 16 and your period never came. That's primary amenorrhea. So no period by the age of 15, and you've had your breasts have already developed, or no period by the age of 13 with no breast development at all. These are the ages that we look at that we say you need to come to be seen by the doctor. I know I said normal periods are between the ages of 9 and 16, but if you've had your breasts, we still want to see you by the age of 15 so that we can start through workup, any evaluation, just to make sure that there's no abnormality, because there are some young ladies who may wait till they're 16 to have their periods, and that can be completely normal. But we want to see you by the age of 15 just to make sure. Secondary amenorrhea is you had your period and now it stopped. So for those young ladies who had regular periods and now they haven't seen it in 3 months, we need to see you in the office for evaluation. If your periods are irregular, you have a history of irregular periods, we usually give you a little longer because we already know your periods are irregular. So we say if you haven't had a period in 6 months, then you need to be seen by the doctor for further evaluation. Oligomenorrhea. Again, the name tells you what it means. Oligo means few, and menorrhea means periods. So you're having fewer than 9 menstrual cycles per calendar year, or a cycle length greater than 35 days. Remember, I said the cycle length is the first day of one period to the first day of the next. So if it's greater than 35 days apart, then you need to be seen by the doctor for evaluation. And many things can cause this. Here's a few that we've already discussed briefly when I talked about a delay in starting your menstrual cycles. Poor nutrition, intense exercise, abnormal thyroid, or a thyroid disease, the gland right here in your neck that produces another type of hormone, diabetes or chronic medical condition that may affect the frequency of your period. Sometimes though, oligomenorrhea is actually caused by the fact that you do not ovulate. This is called anovulatory menstrual cycles. This is the absence of an ovulatory cycle. In these young ladies, they can shift between having ovulation 1 month. At that time, they'll have a normal period. And then another month later or 2 months later, they may not have a period and not ovulate. It is usually characterized by phases of no bleeding that may last for 2 or more months. And then you can have other phases where you have spotting or episodes of heavy bleeding too. And it is common again in the extremes of our reproductive age. So right after you start your period and around the time of menopause, you might have episodes of anovulation that can cause irregular cycles. This also can lead to what's called polycystic ovarian syndrome. This is actually a key component to the diagnosis of polycystic ovarian syndrome, or PCOS, and ovulation. So I put this slide back up here because this is where I said the progesterone is very, very important. So let's look at this. Let's take this step by step. If you don't ovulate, right? If you don't ovulate, then you do not form the corpus luteum cyst that produces progesterone that stabilizes your uterine lining. But estrogen levels are still present. You may not have a fluctuating estrogen level, but it's still elevated enough where the lining is just becoming thicker and thicker and thicker. And you don't have the stabilizing effect of progesterone. When that happens, your endometrium can become excessively thickened. Your uterine walls can have difficulty holding on to that lining. And then when it finally comes out, it's uncontrolled. So you might have spotting all the time that varies between moments where you have heavier times of bleeding, or you can have a really heavy period. It could be a normal length of time. It can be a really, really heavy period because everything's coming out at one time. This is because you don't have that progesterone effect of stabilizing the lining, and you have the unopposed estrogen causing the lining to become thicker at the same time. The other symptom of polycystic ovarian syndrome is elevated testosterone levels. Remember, I told you estrogen can be converted to testosterone. And in this case, because there's no fluctuation in the estrogen levels, that excess estrogen is then converted to testosterone. It can lead to the pimples that you see, can lead to extra hair on your face. That's called hirsutism. And it's the male type hair, the hair that you grow on your head, now growing on your chin or your chest, or in a line between your belly button and the top part of your pubic bone. If you have a lot of hair right there, those are signs of excessive hair, excessive action of the testosterone in your system. And that also shows us that you may have polycystic ovarian syndrome. So for the diagnosis of polycystic ovarian syndrome, you need clinical signs of high testosterone, or if I've seen you to the lab and your levels are elevated of testosterone, that's another symptom. And you can have the irregular bleeding or the intermittent amenorrhea. Polycystic ovarian syndrome, though, is a diagnosis of exclusion, which means I must first look for other reasons for your period to be irregular. And remember before I told you that it can be irregular because of a chronic medical condition like thyroid disease or a severe diabetes is not being treated, if you're underweight. And for polycystic ovarian syndrome, women who are overweight also have an increased risk of PCOS. So the extremes of weight, if your diet is being restricted for any reason, all those things can cause you to have anovulatory cycles. It can lead to polycystic ovarian syndrome, and they can cause it on their own. So I had to look for those things first, rule those out, and then I can give you the diagnosis of polycystic ovarian syndrome. And this is very, very important because PCOS in and of itself is very common. It occurs in 1 in 10 women, and it has certain issues that we need to monitor you for, other serious conditions, such as anxiety and depression. Women who have PCOS have an increased risk of anxiety and depression. They also have an increased risk of being overweight or obesity. And if that endometrial lining is overgrowing and those cells are uncontrolled, they can become abnormal. And later in life, not in your teen years, but later in life, if it's uncontrolled, it can lead to what we call endometrial hyperplasia, which is an excessive growth of the endometrium, as well as endometrial cancer. And there is a connection with PCOS to type 2 diabetes and cardiovascular disease, which is heart disease and things like that. So it's very, very, very important that we know that you have this diagnosis, because once we know it, we can monitor you very closely, we can treat you appropriately, so we can prevent you from developing some of these other conditions that are related to it. Here in this slide, I wanted to show you what the ovary actually looks like when you have a normal ovary that's ovulating like it should versus an ovary that is polycystic. So just like I showed you before in the other slide, you see how your ovary normally recruits one follicle that matures and then releases the egg and ovulates. And then that little cyst becomes a corpus luteum cyst that produces the progesterone, and you have your period. Now, polycystic ovary, because there's a irregulation or dysregulation of your hormones, your ovaries continue to try to do this. They continue to try to do this process. So it's recruiting ovary follicle after follicle after follicle, yet none of them become mature and none of them ovulate. So what happens is you get a picture like this. You have multiple small follicles on the periphery or the outside of your ovary that are hormonally active. So they are producing the estrogen that I told you is then converted to testosterone. So this is what we look for when we get your ultrasound, if we're considering that you may have polycystic ovaries. Now, that said, I want to make sure you guys understand that you can see this in young ladies too who have regular periods. If you have regular periods, you do not have polycystic ovarian syndrome. One of the key symptoms of polycystic ovarian syndrome is irregular periods. Next, what is intermenstrual bleeding? So we kind of talked about that with polycystic ovarian syndrome a little bit, but there are other conditions that can cause intermenstrual bleeding. And what this means is that you're bleeding in between your periods. Other conditions that can cause it, though, some are more common in your adult years, like the endometrial polyps. And this is a picture of one right here. But your adult years start in your 20s. So your 20s and 30s, you can see this. You can see an endometrial polyp that causes bleeding from that area because it's uncontrolled by the hormones. So if you're having bleeding in between your periods, yet you're having regular cycles, but you're seeing the periods, this is one of the things we'll be looking out for, especially when you become a young adult. If you're taking hormones for any reasons, if you're on a hormonal medication and you've missed a pill, you can have spotting or bleeding in between your periods. And sometimes you can be on other medications. Let's say you have a clotting disorder. So your blood clots for some reason. You've had a history of blood clots in your lungs, or blood clots in your legs or anything. You could be on a blood thinner, and this can cause you to spot in between your periods as well. If there's an infection inside the endometrial wall, so endometritis is the lining of your uterus that you shed during your period. If there's an infection there, sometimes called PID or pelvic inflammatory disease, that can cause bleeding in between your periods. And for some young women, even ovulation can cause them to have a mini period. Remember, I showed you the fluctuation of the hormones, and when the estrogen is fluctuating, sometimes when it goes down, you can have some spotting in between your periods at the time of ovulation. This is not very common though. As you can see, it occurs in less than 3% of cycles. And when we say cycles, we mean everyone cycles, all women cycles, so less than 3%. And then there can be conditions of the cervix itself that can cause spotting in between your periods. Some of them, again, are not common in your adolescent or your teen years, like cervical cancer and cervical polyps. Cervical polyps are the same as these, but they're coming out of the cervix. This is a picture of a cervix here. Now, the cervix is the bottom portion of your womb. That's the portion that we actually see when we're doing your exam, and we're looking inside your vagina. So this is what we see here. What I want you to notice here in this cervix is that you have a light pink area and a hot pink area. And this is actually what we see in teens. This is very common in teens. In adult women, this actually hot pink area is covered by the light pink area. And these are just two different types of cells. Squamous cells, light pink, cuboidal cells. I know you guys most of you are in secondary school, so you know what a cuboid looks like. Cuboidal cells are the hot pink areas. And when you are, let's say, if you're a teen and you're sexually active, you might have spotting after intercourse or in between your periods because of these cells right here, okay? So these is called the ectropion, and it's not abnormal. It's a normal part of our growth and development. And when you're mature as a woman, that goes away. And then you can have spotting we talked about the endometrial lining becoming overgrown or endometrial hyperplasia that can lead to cancer. Again, not found in teens, but can be found in young adulthood if your PCOS is not well controlled. Now let's talk about heavy regular menses. Now, heavy menses can be regular periods that are heavy in quantity, so the amount of bleeding that you're having, or the length of time that you're bleeding. So it's lasting more than the 8 days. And it's an excessive amount of blood loss that interferes with your life. We diagnose heavy periods if you tell me that you're changing your pad or tampon every 2 hours or less, so either one or both, you need to wear more than one sanitary product at a time, meaning you can wear 2 large pads at one time, or you're wearing one pad and a tampon at the same time. That's not normal. You shouldn't need to use more than one sanitary product at one time. Women, you do that because you know you're bleeding heavily, you're active during the day, and you don't want to soil your clothing or your bedding or your PJs or anything like that. So if you think you need more than one sanitary product at a time, then your periods are heavy, okay? Your heavy periods can be associated with clots and cramping, but not always, okay? So there are many different things that can cause you to have heavy periods. Most of these are only found in adult women over the age of 20. Fibroids, endometrial polyps, adenomyosis. And adenomyosis is important. We'll talk about that briefly because that is endometriosis, which we'll talk about in a few minutes, that grows in the wall of your uterus. But again, that's a finding that we find in adult women. Endometriosis, though, can be found in teens, and we'll talk about that briefly. Ovulatory dysfunction, we already talked about PCOS, polycystic ovarian syndrome, and how the lining can become thicker and thicker and thicker, leading to heavy bleeding. So that's ovulatory dysfunction. Infections we've discussed already, endometritis, cervicitis, those are infections of the genital organs. Medications, hormones, or medications that you're taking because you're on a blood thinner can cause heavy or prolonged bleeding. And then cancer in those locations as well. There's one disorder that I want to focus on just because for our teens that is usually diagnosed in your teen years. Not always, but usually it is. And this is disorder of hemostasis. What that means is that you have a problem clotting your blood. Now, we talked about blood clots being formed in your body. Now we're talking about the fact that your blood doesn't clot normally. So if it doesn't clot normally, which means that your blood doesn't stop bleeding at the normal rate, then you may have a disorder of hemostasis. And there are many of them out there that you should be aware of. But the key thing is that when you have your very, very first period, you have the heavy bleeding, which is not usual. Most young ladies who have their first period have a very, very light flow, mainly because they have not started ovulating yet. If your first flow is very heavy, you need more than one sanitary napkin, you need one pad, and you need a tampon at the same time, or your period is lasting for longer than 8 days, this is a consideration we will need to consider, that you may have a bleeding disorder. And you may have had clues from that you've had this disorder your whole life, because these things are genetic. So before you started your period, you may have had frequent nosebleeds. You might have had easy bruising, meaning that you're walking by a doorknob, you just gently tap on the doorknob, and now all of a sudden you have this big bruise on your hand or your arm. You might have what's called petechiae. Petechiae are those little red dots that you see on what we call mucosal surfaces. The mucosal surfaces are those surfaces that are like in the whites of your eyes, in your mouth, and in the vaginal tissues. You see red dots there, then that could be a sign that you may have a disorder. We've also a disorder of hemostasis, or bleeding or clotting. Gums bleeding. You're brushing your teeth and your gums always bleed, even though you brush them twice a day, you're flossing, you have very, very healthy teeth, but you're still bleeding. That might be a sign that you may have a disorder of hemostasis. And lastly, if you're having a minor surgical procedure, such as pulling your teeth, you have a tooth that needs to be pulled, but your doctor tells you afterwards you had a lot of bleeding and we had to put a lot of pressure on there or use some medication to stop the bleeding because it just wouldn't stop, then you really should go to your GP and be evaluated for a minor surgery, for a disorder of hemostasis. But keep in mind that a lot of times I'm the first person that does this evaluation, because you don't know that you have this condition until you start your period. So now we've talked about what a normal period looks like, why we have our periods, what an abnormal period looks like with a heavy flow, prolonged bleeding, and irregular periods. So let's talk about the other side of your period, the pain that may be associated with it. And that's what this word means. Dysmenorrhea just means painful periods or painful menses. It is usually a crampy pain that can be intermittent in intensity, but for some young ladies, it may be continuously a dull ache during their periods. It is very, very common, experienced by most women during their reproductive years. The pain itself typically starts 1 to 2 days before your period starts, or it can start with your menstrual flow. And it then gradually diminishes over a 12 to 72-hour period. It will occur with most, if not all, of your menstrual cycles, and it's usually confined to that lower abdominal area that I talked about earlier, that's between your belly button and your pubic area. The pain is usually right in the middle, but in some women, they can have lower back pain and or thigh pain associated with their periods as well. And if severe, it can impair the quality of life. So a lot of times when you go see the doctor, they'll ask you on a scale of 0 to 10, how would you rate your pain? If you say your pain is rated anywhere between 7, 8, 9, 10, which is the worst pain of your life, then more evaluation needs to be done. Also, if you have any associated symptoms such as nausea, vomiting, diarrhea, fatigue, or headache, or if you're missing school because of your pain, more evaluation needs to be done by the doctor. So just like your periods and amenorrhea can be separated into primary and secondary, so can dysmenorrhea. What this means, primary dysmenorrhea, means that there's no physical or structural cause that we can find that is causing the pain. And we'll talk about what those are. Those could be in just a few seconds. Again, it's the same type of pain, a recurrent crampy pain in your lower abdomen that occurs in your period, and it typically begins when you're a teenager, after your cycles become ovulatory, when you start to ovulate. It is more often found in teens and young women, and it usually is treated successfully with pain medications and hormonal medications. It tends to improve as you get older and often after you start having your children. It is a diagnosis of exclusion. I wanted to show this to you because when you come in and you tell us your pain is a 7 to 10, and you're having associated symptoms, then we need to look for other reasons for your pain at that time. And only if and only if we can't find anything else that can cause your pain, do we call it primary dysmenorrhea. Secondary dysmenorrhea, the same pain symptoms, the same locations, but it's typically caused by some kind of underlying condition. And if it can be resistant to effective treatments. So the pain medications and the hormonal medications that we use to treat dysmenorrhea, primary dysmenorrhea, usually they do not effectively treat secondary dysmenorrhea caused by endometriosis, fibroids, or adenomyosis, okay? It can work initially, but then if they stop working, again, that's something we should be looking at you to evaluate you for other conditions. Endometriosis. I wanted to point this out because as a young doctor, when I first started learning my trade, I was actually told that endometriosis did not exist in teenagers. And that's something that everyone before me was told as well. Like Miss Odelia said, it was thought that pain during your period was normal and we should just live with it. But honestly, endometriosis is something that is a condition that can be managed and you shouldn't have to live with. It is treatable. It's not curable, but it is treatable. So what is endometriosis? So let's look at this top picture really quickly. This is your womb again, and that lining that you have your period from is here. That lining, sometimes the glands from that lining grow on the outside of your womb. Can grow on the surfaces of anything that occurs inside your tummy. So here you can see more inside your tummy, where you can see your uterus or your womb cut in half. This is your bladder, and this is your bowels right here and right here. Endometriosis can be stuck on any of these areas and can cause significant pain. It can cause pain because during your period, your menstrual flow is occurring, correct? You're releasing fluid. Same thing happens at the top in these locations also. You release fluid inside your abdominal cavity, and that fluid is what causes the pain. And it can cause scar tissue to form as well. So when scar tissue forms inside your body, it's trying to protect your body, the scar tissue. That's the purpose of it. But when the scar tissue forms, it can form between where the locations where the endometriosis is located. So let's say the endometriosis is located on the back wall of your uterus, and behind there is your rectum, or the bottom portion of your bowels, and they get stuck together. Now, normally these two organs will kind of move in their own directions, but when they're stuck together, they start moving together. So you actually might notice you have pain when you're having a bowel movement, or what we call defecation. Same thing about with your bladder. If they're stuck together or there's endometrial implants on your bladder, that can cause pain there when your bladder fills and puts pressure and stretching that area. And sometimes even when you're releasing your urine, when you're going to the bathroom, because now it's pulling down on it too. So endometriosis is one of those things that can cause severe pain during your period. And for some women, even in between their periods, they are in a chronic state of pain. And like I showed you this picture here, the endometriosis can also grow in the wall of your uterus. This is more commonly found in adult women over time and cause the uterus to become enlarged and heavy and painful also. This is a condition that we definitely need to keep in mind when you come to see us as your doctors, because it is a chronic condition that can get progressively worse. It can affect your life in the future and your ability to have children in the future. And we don't want that. We want you to have the family that you want, and we want to control the pain that you're in as well. And lastly, this is something that is very, very, very rare. But this is another common symptom of pain. This is another reason you might have pain during your periods. And more commonly, it will usually show itself with your very first period or your periods in that first 1 to 2 years as your periods become ovulatory and more regular. So these are developmental anomalies, meaning when you were inside your mother's tummy and your uterus and your womb was starting to develop, it did not develop normally. What happens around the 8th to 20th week of life inside your mom's tummy is that two portions of your uterus and two portions of the upper portion of your vagina, they come together in the middle, and this middle portion then goes away and it becomes one. And then that one area will then have your period and will come out the vagina, and that's normal. But for some young ladies, very rarely, you might have the vagina not formed. So that's what this picture over here shows. You have the top portion of your womb. You don't have your cervix, so there's no opening out, and there's also no vagina there's no opening to the outside. So what happens in this case? You have your period, but there's no menstrual flow to the outside, but there is flow going out these fallopian tubes into your abdominal cavity, can lead to formation of endometriosis and pain. Same thing with this one. You have a vagina, but you don't have a cervix. So again, there's no outflow for the menstrual flow. And in this one, you actually have a flow because this side is open, but this side is not, because this portion of the vagina is blocked. So all three of these can cause significant pain during your period for two reasons. You have this amount of blood that's being stuck inside that has no way to get out down here, and it's causing a lot of pain and pressure in your tummy at the time of your period. But also, that blood, that menstrual flow goes out the fallopian tube into your abdominal cavity, causing endometrial implants in your abdominal cavity, which in and of itself can cause pain. So again, this is a very, very rare condition, but if you come to me during the first 1 to 2 years of your menstrual life, you tell me you're not having a menstrual flow, but every month you have this significant pain that is debilitating, this is one of the first things I'm going to think about and evaluate you with for. So all that being said, when should you go see a doctor? And I've already mentioned them all, but I'm going to put it here all in one slide so you guys can have a good idea of when you should see your doctor for further evaluation. So if your period has not started by the age of 13 and you don't have any breasts, if your period has not started by the age of 15, but you do have breast development, you should go see your doctor for further evaluation. If you're skipping more than 1 month at a time, it's occurring over and over again, if your period is lasting more than 7 to 8 days, also you should go see your doctor. If you're having heavy periods, you're changing your pads, your tampons, less than every 3 hours, you're needing to use more than one sanitary product at a time, go see your doctor for further evaluation. And lastly, if you're having severe abdominal pelvic pain during your period, with or without menstrual flow, go see your doctor. Thank you, guys. Now I'm here for all your questions. That's my favorite part, actually.
Thank you so much, Dr. Yarbrough. We already have some questions in the chat.
Perfect.
So if anybody else has questions, please place them in the chat as well, or raise your hand. We'll acknowledge you and you will be able to ask your questions. First two questions came from one person, and those questions are, what can be done to reduce or lower testosterone levels? We start with that one. What can be done to reduce or lower testosterone levels?
Yes, so the testosterone levels can be reduced actually with hormonal medication. When we put you on hormonal medications, that actually will suppress the estrogen and progesterone levels, as well as the production of the testosterone levels. So that will decrease the levels, and you will actually see that some dermatologists even will recommend starting a hormonal medication for the acne. So you may have regular periods, but if you have severe acne, which is a sign of overactive or active testosterone levels, then they may actually recommend putting you on a hormonal treatment for that as well. So hormones is the main way to decrease testosterone levels. There are other medications as well, such as spironolactone, which is less commonly used, but that can also decrease testosterone levels also.
Okay, and the second part to that question is, can a reduction in the use of processed sugar reduce the symptoms of PCOS?
And that's a very, very good question. Now, I didn't mention diet, and one of the things I was thinking about was putting diet, but that's one of those things that is really still an ongoing research. Diet is very, very important. There's no doubt about it. So a very healthy diet is the best way to reduce a lot of things. Sugar for one
medication is, can a reduction. Okay, I was just checking our Facebook Live to see if there are any questions in the chat. Somebody there was asking about where you're located, Dr. Yarbrough.
Oh, okay. Well, let me finish the last question first. I wasn't quite done.
Sorry.
Barbados. But the diet is very important. The diet is very, very important. So sugar in and of itself is inflammatory, right? So it's not you want to eat more anti-inflammatory foods. Sugar is more inflammatory. So can it have an effect on your period? I would say yes, because a person who eats a lot of sugar can also increase their weight too. So they may be at an unhealthy weight that can then affect their period. So it may be a direct cause, meaning eating sugar, your periods don't come normally. But if you're eating a lot of sugar and eating an unhealthy diet, then you're more likely to put on weight, which can then lead to irregular periods and so forth.
And then another thing to doctor, PCOS causes weight gain in and of itself. So it's like you're a hamster on a wheel.
It is. It's a catch-22. I always call it, that's what I call it, catch-22, because your body's trying to work and is trying to have a period, but it just can't do it. And when it keeps producing those excess hormones, it just makes it worse, unfortunately.
Yes. Another question about PCOS. Can you have excessive hair and not have PCOS? And if so, what could be the possible cause?
Yes, to answer your question, you can have excessive hair. Now, it depends on what type of hair you're talking about. The PCOS one we're talking about is the kind on your head and in your genital area and underneath your arms. If you've seen that type of hair on your face or your chest or your upper back, then we consider that excessive or hair or hirsutism, okay? If it's the thinner hair, like the kind you see on your arms or your legs, and it's not thickened, but you have a lot of that hair, technically that's not hirsutism, right? That's not that type of hair we're talking about. There are other conditions that can cause hirsutism in and of itself is a condition. It's excessive hair growth. Many things can cause it. It's kind of out of my wheelhouse. That's not my specialty, but many things can cause it. And if it's bothersome to you, I do recommend going to see at least first your general practitioner. They can get you started, and then they may refer you to an endocrinologist or a gynecologist, depending on what the condition is.
Okay, next question, doctor. What other hormone treatments are available other than those used as contraceptives?
It depends on what you're asking for. So hormonal medications are the same as contraception for the most part. That is correct. So the contraceptive pills, the combined oral contraceptive pills, progesterone-only tablets, the injectables, you have injectables that you can use also. And then you have the patches. There's a patch that you can wear. And you can use an IUD that has hormone as well. Now, if the only purpose for the device is for contraception, there's a non-hormonal IUD as well that has no hormones whatsoever. But if you need regulation of your period, the best way is going to be a hormone, unfortunately. There's no other way to regulate your period without hormones, unless there's other things going on. Again, I said this is a longer answer to the question, but we must first check you for other conditions like your thyroid to see if that's your issue. Because if your thyroid is causing your period to be irregular, then you take thyroid medication. You don't need the hormones, right? So it just depends on what the condition is that's causing your period to be irregular.
This person has PCOS and they have used various types of contraceptives, including the progestin-only injections or the tablets and so on, and they have severe reactions to them. So that's why they're asking about other hormone options outside of the contraceptives.
That's going to be very difficult because we need to figure out what you need, right? So I would need to know exactly what your reactions are, and I need to know your symptoms of PCOS, right? So are you having prolonged bleeding, or are you just not having a period at all? The treatment options would differ depending on what your symptoms are. So that is definitely a conversation you should have with your gynecologist, because that you may have to, for lack of a better word, play with the different options for your treatment options. One of the other ones that go along with the type 2 diabetes is insulin resistance. And I found that for some women and some young women, putting them on a diabetic medication or anti-diabetic medication, such as glyburide or metformin, can actually, that's non-hormonal. That's actually a medication for diabetes. But because PCOS is connected and related sometimes to insulin resistance, research has shown that putting them on the metformin can actually regulate the periods. So that may be an option for you if you can't take the hormones.
Okay. Next question. Would a doctor determine if I can get hormones with a test for my terrible acne, or do I just ask for some and the doctor would give me without a test?
If the only thing you have is acne, then you shouldn't need a test, because acne in of itself tells you that you have testosterone that is acting on your skin, right? So you don't need a test to prove that. You've already proven it. So if that's the only reason you need the hormones, then your doctor can give you that prescription. It depends who you're talking to, though. They may want to start with other treatments first, or they may want to start with the hormones. It just depends on your doctor's preference. And that's a conversation you should have, because you are the patient. So you should have that conversation with your doctor.
Okay, next question. What is the reason for having endometriosis and urinating a lot? So I guess they're asking about the connection between endometriosis and frequent urination.
Endometriosis, it depends. You can have implants of endometriosis on your bladder. That's very true. That can cause you to have scar tissue formation on the bladder. Let's say you have endometriosis there and you have the scar tissue formation there. If your bladder starts to fill up with the urine and you're stretching, you may have the sensation of urination, needing to go to the bathroom sooner than you would if the scar tissue wasn't there. So that's a very real possibility for sure.
And I can testify of that. That's a symptom that I have with my endo. I would feel the need to urinate, and then when I get to the bathroom, nothing is there, but I feel like my bladder is full. Right. So I'm always having to be in the bathroom with the frequent urination.
That's the pressure from the weight of everything there. Yeah.
It's heavy. It literally feels like there's a weight there.
Correct.
Yeah. Okay. Can inositol be used for PCOS?
In what?
Inositol.
Oh, inositol. Actually, that's not one of the ones we usually recommend. And that's a medication I don't use. So no, I would not use that for PCOS.
Okay. If there are any other questions, we've come to the end of the typed questions. So if anybody else has a question, you can raise your hand and we will let you go ahead and speak. If not, you can continue just typing your questions here in the chat before we end our session. Okay, I don't see any more questions being, okay. Somebody has raised their hand. Go ahead, Paulina.
Okay, good night. Thank you very much for this session. I really wish I would have had this information when I was a teenager. I was diagnosed with polycystic ovarian syndrome since I was 15 years old. So that's 20 years now. It's very frustrating to deal with at times, because most times you have these symptoms and sometimes you're not having a period, other times you're having lots of pain, but no period. Another time you have heavy, heavy bleeding with lots of clots. And you go to the doctors and they do ultrasounds. For me, I've been told recently in the ultrasounds that I've done that there are no cysts on my ovaries. My endometrium is normal thickness. Everything seems fine on an ultrasound. But I'm just having these frequent bleeds with lots and lots of clots. My testosterone is through the roof. And, you know, sometimes it could be very frustrating. And as you rightly said, people who suffer from PCOS tend to have anxiety and depression. So most times I tend to have depression as well.
Yeah.
So I really wish I had this information when I was younger.
Yeah, and that's why I'm here, because I actually, and I'll be a little personal briefly, but the reason I got into this field is because my best friend of greater than 30 years, she struggled with endometriosis, PCOS issues her entire life. And again, at that age, they didn't consider having any problems, right? It was normal. So so I definitely understand. And I'm sorry that you're going through that. I'm sorry. But I think you definitely should still see your doctor. Just because you don't have cysts on your ovaries doesn't mean you don't have PCOS. Remember, that picture I showed you with those little cysts on them is not diagnostic of PCOS. That's just what we can see if you have PCOS. But we don't use that to diagnose PCOS. PCOS is diagnosed from irregular periods and the high testosterone levels, whether it's levels in your body or clinical signs of it, like the acne and the hirsutism. That's how we diagnose PCOS. So you can still be treated even if you don't see the cysts on the ultrasound.
Yes. And I guess I'll just use this opportunity to share a little bit more about my story, because as you were doing the presentation, Doctor, my best friend and I were actually chatting on the side about how much we wish we had this information when we were younger. Yeah. Because as I said, I started having my periods at age 11.
Yes.
And I've never had a normal period in my entire life.
Yes.
That is almost 30 years.
Yes.
I have never had a normal period from the age of 11. It was always heavy. You talked about a normal period being changing your pad every 3 hours. I've never had that experience. It was from the beginning. Every half hour to an hour, I have to be running to the bathroom. It was always heavy. My period has never been below 8 days long, always with clots, the pain, having to stay home from school. My mother was my first advocate.
Yes.
She took me to different doctors, and everyone would tell us the same thing. Oh, that's her normal. Oh, she'll grow out of it. Oh, just give her some Tylenol, some Advil, she'll be fine. Nothing worked. It was when I was 16 years old, a general practitioner diagnosed me with dysmenorrhea and menorrhagia. But nobody ever dug deeper to find out what was the cause of all of these things. And so I just went from doctor to doctor to doctor from the age of 11 until I was in my late 20s. By that time, endometriosis had destroyed my right ovary. And so I needed surgery because initially they thought it might have been a tumor that was growing because diet wasn't helping, exercise wasn't helping, nothing was helping. So I eventually needed urgent surgery. And when they went in, they found endo, and I lost my ovary because of an endometrioma.
Yes.
And then since then, I've been diagnosed with all the other conditions. So sometimes I just feel like a walking gynecological textbook. I mean, and I wish more doctors would understand that just because you're young does not mean that you cannot have these conditions.
Right.
And so many more of us could be helped at a younger age, preserving our fertility at a younger age.
Right.
Instead of waiting until you're in your late 20s and 30s when all of the damage has already been done. Right. My uterus is adhered to the back of my pelvis. Like, I have so many issues now, and I honestly believe that if it was caught earlier, I would be in a much better place right now.
For sure. Because I mean, even with, especially endometriosis, right? Because endometriosis is progressive. And it's progressive, so it's going to get progressively worse. and possibly cause issues with fertility, as you mentioned before. So it's something that should be treated early, and whether that's medication or surgery or whatever your doctor decides is the best treatment for you at that time, and what you decide is the best treatment for you at that time, because we need to suppress it to give you that chance to have a family in the future and to control the pain, and prevent all the possible side effects that can occur with it. So yes, for sure.
I have a question for myself.
Yes.
Do you find that there is like a familial component in these illnesses, that if one member has it, that there's a greater chance that other family members will also have this same condition like endo, or a similar condition like adeno, fibroids, PCOS?
For certain. And every time I see a teenager, one of the first things I ask for is, especially if they come in with severe pain, right? First thing I ask, is there anybody in the family with endometriosis? The reason for that is because especially if there's a first degree relative is your mother and your sister, right? If there's a first degree relative with a known history of endometriosis or painful periods or a history of infertility, so those are the three questions, then your risk of having it is 7 to 10 times higher.
You know, that leads me to my next question, because I have realized that like my mother and that generation of women would have gone through a lot and never were diagnosed. And
right.
I mean, and I'm sorry, Mom, but I'm going to share a little bit of my mom's story. The reason why she was my advocate is that she had horrible periods, absolutely horrible. So when she saw that her child was going through the same thing, she was like, it's not going to happen. My child cannot have the same experience as me. And for years, she fought to get a hysterectomy. And for years, doctors denied her that.
Yeah.
Until they realized, okay, we can't keep doing this. This woman is going to die or have serious medical complications if we don't do something.
Right.
So she eventually had a hysterectomy. Nothing was told to her about what the findings were, nothing. It was not until 2017 when I was diagnosed with endometriosis and I started reading about what it was, etc. I saw that if your mother or sister has endometriosis, you are how many more times likely to have it yourself. And then my mother remembered she had her biopsy report. It was given to her. No, it was never explained, but it was given to her.
Right.
And on her biopsy report was the word adenomyosis.
Yep.
So I'm asking her, Mommy, did the doctor tell you what this is, what you had? She said, no, they just gave it to me and sent me on my way. And so my mother had adenomyosis.
Yep.
And then now I have endometriosis, adenomyosis, PCOS, and fibroids.
She likely had endometriosis as well, though.
She probably did, and they just did not test for that.
Right.
And so I often feel like my mother's generation, they were done such a great disservice. And there's still so many women suffering without answers and being pushed around, for lack of a better term. And I just wish that this sort of information was given in school.
Yes.
So that by the time you started having your period, you already know what to expect. You know, if these certain things happen, that this is not normal and I need to go see the doctor. And I wish more women would not push the narrative that pain is normal. Right. And the type of excessive pain is not. It's not. No. It is a sign that something is wrong and that you need help.
Right. That's very true.
Yeah. And the narrative of being the strong Black woman, fellow ladies.
Be strong and Black without being in pain. I don't see why we would be
let's not be in pain.
Yeah. Very true. Very true. Well said.
So yes. Are there any more questions before we end tonight's session? I don't want to leave anybody's questions unanswered. Okay, we don't have any more questions. We did have a comment, Doctor. Somebody asked if you'd be willing to share your PowerPoint presentation.
Oh, sure. Yes, of course.
Okay, so you can email it to me, and then if anybody is interested, you can always send me a message and I will send it out to you. Oh, a question just came in, doctor. How is endometriosis diagnosed?
Yes. So endometriosis is truthfully only diagnosed through surgery, which means laparoscopy. Most time, 9 times out of 10 is laparoscopy. And during that procedure, when you're putting a small camera inside and looking inside your tummy, we take a biopsy of the area to diagnose it through the pathologist. But you do not need surgery in order to be treated for endometriosis. And what I mean by that is that, especially in our teen years, the first thing we don't, let me go back. We don't go to surgery right away, right? So if you come to me and you say you have severe pain with your periods, we're going to try to manage it with medication first, only because endometriosis is chronic, okay? And it's very likely you're going to need more than one surgery in the future. So we don't want to start off with surgery. We want to try to control it first, initially, with medication. And if we can control it with medication and suppress the growth of further endometriosis at that time, we'll do that. But if we put you on medication and the medication is not controlling your pain whatsoever, then of course we have to move to surgery, even in your teen years, because we'll need to remove as much of the endometriosis as possible so that it can decrease your pain. That being said too, as a teenager, a lot of times when we do the surgery, there's very little in there to remove because it's so early still, it's hard to see sometimes. So but we don't want it to get worse, right? That's not what we're trying to do. So we'll get there, we'll do the surgery, we'll remove what we can see, and then still put you back on the medication because we want to suppress it from growing back. We're trying to control your pain. We're trying to prevent it from getting worse. We're trying to get you to adulthood so you can start having your families and things like that and controlling your pain at that point as well. So the only way you can truly diagnose it is through surgery to get a biopsy to prove that the endometrium is now growing on the outside of the uterine wall, but we don't need that to treat you.
Okay, somebody is asking for your views on hysterectomy for teenagers.
Oh, no. So there are reasons, right? There always can be a reason to need a hysterectomy as a teen. One of those, if you remember the picture I showed you where the womb did not develop normally and there's no outflow to the outside, then that young lady actually is going to need a hysterectomy because there's nothing we can do to connect the inside of your womb to the outside. Because you need a cervix there and everything, there's nothing we can do. But the only way we can prevent you from being in that much pain is one, we can put you on suppressive medication, but the other would be hysterectomy in the long run. But hysterectomy as a teen is not our go-to. Understand that. That is the last thing in the world we ever want to do, ever, in a teenager. So if there's something else we can do, we'll try that first.
Okay, doctor, can you put back up the slides with your contact information? We have several people asking for your contact information.
Here we go. Let me put it up so you can just see that too.
Yes. So take a picture, screenshot it, so you can.
This is in my way. Hi, there we go.
Yes. So you can contact Dr. Yarbrough.
There we go. You can see it better.
Yes. Is everybody seeing it? Great. So this is your chance to take your screenshot and so on. Okay, have we taken our screenshots? I am assuming so. Okay.
Yes. All right.
And right. So are there any other questions? Okay, I don't see any other questions. I don't see any other hands raising. Okay, somebody said yes to other questions. Okay, go ahead with your question.
Or maybe yes,
No?
the screenshot. Maybe it was just the
Oh,
screenshot.
so screenshot. Oh, okay. Oh, yes, they have a question actually.
Okay.
What advice would you give to parents who have daughters that may be affected by endo? And I guess other conditions as well.
Well, if you suspect it, I say if you suspect endometriosis or polycystic ovarian syndrome, or if there's any concerning issues with your daughters in their periods, go see the gynecologist. You can see your GP first or your pediatrician if you feel more comfortable, but more than likely they're going to send you to the gynecologist anyway. So you can go see the gynecologist, and so we can have a discussion. One of the first things I do, I didn't mention this, but during the exam, there's not usually a pelvic exam. I don't do pelvic exams on young women and our teens and kids unless I need to. So most times I don't do that. So that's one fear and worry that you can just put away, because that's not what we're going to do. We're going to sit down, we're going to talk about what the issues are, and then if you need more further evaluation, we'll send you to the lab for hormones, or we'll send to a lab to check your own natural hormones, or we'll send you to get an ultrasound at that point. But you don't necessarily need an exam. So if you're concerned, please don't wait. Don't wait. Go see the gynecologist, and they can let you know whether it's normal or not. You know, because sometimes irregular periods, like I said, in the first few years are normal, and they will self-regulate, but sometimes they're not.
Yes, thank you, doctor. So thank you everyone for being here tonight. Thank you again so much, Dr. Yarbrough, for accepting our invitation and for giving us this wealth of information. I am so happy that we were able to stream it live so that it will be there for others to see. We are also recording it, and so we will share that as well if anybody also requires the recording. Thank you so much, everyone, for being here. Thank you for joining us. I hope this session was very helpful for you. You have seen Dr. Yarbrough's contact information. So if at any point in time you need to reach out to her, you know where to find her. And you can also reach out to us at she.is.lotus on Facebook and on Instagram. It is Endometriosis Awareness Month. You see I'm in my yellow. So I encourage everybody to wear something yellow this month in support of all those who live with endometriosis and who suspect that they may have endometriosis. Let's wear something yellow. Please follow our socials. We also have some giveaways going on this month for Endo Warriors and our supporters. So we're looking forward to having you join us over on Instagram and on Facebook. And Dr. Yarbrough is on Instagram as well.
I am. Thank you so much for having me. I really appreciate it. And I will send my presentation too.
Yes, thank you so much. And somebody also wanted to tell you, thank you, Dr. Yarbrough, very comprehensive and enlightening presentation.
Thank you guys so much. I appreciate it.
All right. Good night, everyone, and have a blessed evening.
Good night.
Good night.